Today I'll be talking about recurrent tenosynovitis. Recurrent tenosynovitis is a standardizing tenosynovial inflammation of the first dorsal compartment of the wrist. The diagnosis is made clinically. It usually affects women more than men and at the age of 30 to 50 years old, and commonly at the dominant hand. There are multiple risk factors for recurrent tenosynovitis, which includes overuse. It is common in construction worker, labor worker, golfers, and also athletes using racket sports. Besides that, post-traumatic and postpartum also can increase risk of recurrent tenosynovitis. The recurrent tenosynovitis usually occur due to thickening and swelling of the extensor retinaculum, which increase tendon friction. For the anatomy, there are 6 extensor dorsal compartment of the wrist. The first dorsal compartment consists of abductor pollicis longus and extensor pollicis brevis. The second dorsal compartment consists of extensor carpi radialis longus and brevis. The third dorsal compartment consists of extensor pollicis longus. The fourth dorsal compartment consists of extensor digiti, extensor indicis proprius and extensor digiti communis. The fifth dorsal compartment consists of extensor digiti minima, and the sixth dorsal compartment consists of extensor carpi ulnaris. Usually, patients with recurrent tenosynovitis presented with gradual onset of radial-sided wrist pain, which is aggravated by gripping and lifting things while the wrist in neutral position. For the examination, there might be swelling over the first dorsal compartment on inspection. On palpation, there might be tenderness over the first dorsal compartment at the level of radial styloid. There are 2 special tests that we can do to test for recurrent tenosynovitis. The first test is finger-thumb maneuver. It is performed by grasping the patient's thumb and quickly abducting the wrist ulnarward. The test is positive when there is a pain at the level of the tip of radial styloid. The second test is Eckhoff maneuver. It is performed by anally deviated the wrist while patient clenches the thumb in fist. The test is positive when the pain is relieved by extending the thumb. Imaging usually is not needed for diagnosis, but we can do X-ray of the wrist AP and lateral to look out to rule out any fracture or arthritis. Besides that, we can do ultrasound to look for tendinopathy, effusion, or arthritic changes. The differential diagnosis for recurrent tenosynovitis includes bacillar thumb arthritis, intersection syndrome, which is an inflammatory condition between the first and second inflammatory condition at the crossing point between the first and second dorsal compartment. And other differential includes flexor carpi radialis tendinitis. For the treatment of the recurrent tenosynovitis, it can be divided into operative and non-operative. The non-operative usually is the mainstay of the treatment. We can prescribe patient with NSAIDs, for example, Celebrex, to reduce pain and inflammation. We should advise patient for rest and immobilization with thumb spica splint. Besides that, we can also refer patient to physiotherapy for pain modalities, for example, ultrasound and warm compression. We can teach patient a few exercises, which includes thumb lift, opposition stretch, thumb flexion, finger-thumb stretch, wrist flexion and extension, and also hand gripping. Besides that, we can also offer for steroid injection into the first dorsal compartment to reduce pain and inflammation. For the surgical management for the recurrent tenosynovitis, usually they will do surgical release of the first dorsal compartment. It has a few possible complications, which include injury to the sensory branch of the radial nerve, neuromalformation, complex regional pain syndrome, and also the failure to decompress and recurrence. The prognosis for recurrent tenosynovitis, usually most cases resolved with non-surgical, non-operative management, but it has high recurrence rate. Thank you.